Good afternoon. Let us come to order. Welcome to our subcommittee. Tony Thurman, it's my honor to chair this. I'd ask that we start by calling the roll.
Thurman.
Here.
Bonta. Chu.
Here.
Grove. Jones.
You all have successfully scared off all of our committee members, but in spite of that, we appreciate Mr. Chu's courage in joining us, and we will move forward. We have a fantastic panel of speakers for you today. We intend to discuss a host and myriad of issues in the healthcare arena. We will be keeping it brief, as we want to have time for a question and answer. We welcome the participation of public comment and advocates. We will be asking you to keep your comments to 1 minute, as we hope to really push efficiency so that we can save the balance of the time for the policy making that the members of the committee's members will be doing. As we say that, I'd like to welcome my colleague, Assemblymember Groves. We will now move, and let the record reflect Assemblymember Groves' presence. We will move to our first presenter, Mari Cantwell, Chief Deputy Director for Healthcare Programs at the Department of Healthcare Services.
Thank you so much. Thank you for having me. So the first issue just requested that I give an overview of the Department of Healthcare Services. I'll get into the budget issues in the next item, since that's really about the Medi-Cal estimate. So DHCS has our mission to provide Californians with access to quality health care, including physical health, behavioral health, substance use disorder services, and long-term services and supports, and dental. Our single largest program is, of course, the Medi-Cal program, which today provides health care coverage to over 12 million individuals. This is nearing a 3 million person increase over the last 18 months, due in large part to the Medicaid expansion under the Affordable Care Act and the associated changes in eligibility and enrollment that also resulted in significant increases to people who were previously eligible but not enrolled. As it stands today, Medi-Cal covers about 1 in 3 persons in California. To put it in the national context, our program is the single largest Medicaid program in the nation, nearly twice the size of the next largest state. And the size of our increased enrollment alone, that 3 million people, is 5 times the size of the next largest state's increase, or on its own would be the 5th largest Medicaid program in the country. Outside of Medi-Cal, the department operates several other programs, including specialized programs for children and adults with specific diseases, including genetic diseases and cancer screening and treatment programs. As noted in the agenda, the department has undergone significant transformation over the last several years, including the consolidation of programs from other prior departments, such as the Department of Mental Health, the Department of Alcohol and Drug Programs, and the Major Risk Medical Insurance Board. The governor's January budget includes a total of $98 billion for the support of DHCS programs and services, of which about $19 billion is in state general funds and $61 billion is in federal funds. In addition, the January budget proposes the establishment of 79 new positions, 51 of which are limited term, and the extension of 18.5 existing limited term positions, and the conversion of 34 existing limited term positions to permanent. So I'm happy to take questions on that, or we can move on to the Medi-Cal estimate. Okay, sure. So I was asked to provide an overview of the Medi-Cal estimate as well as the major policy and fiscal proposals in the budget. The proposed budget in the Medi-Cal estimate is $95.4 billion total funds, an 11.3% increase from the estimate of the current year, the majority of which is in federal and other funds. The state general fund increase is a 4.3% increase from the current year estimate. There are several new major policy proposals which I'll highlight here, but I know we'll go into further detail either in this hearing or in later hearings, so I'll try to keep it at a high level. First, one of the most important initiatives that the department's undertaking this year is the renewal of our Medicaid waiver. Currently, California is in the last year of a 5-year Medicaid waiver called the Bridge to Reform, which has been fundamental to the successful implementation of the Affordable Care Act, and it expires in October. We will be seeking a 5-year renewal of the waiver in order to continue to support ACA implementation, improve the health care quality and outcomes for our beneficiaries, and provide for the long-term fiscal sustainability of the Medi-Cal program through delivery system transformation and alignment. We have been engaged in an extensive stakeholder process to discuss the concepts for the waiver renewal, and we're targeting a submission of the waiver application to CMS at the end of March. Currently, the budget just reflects the ongoing funding of the existing waiver, and we're working on looking at revisions to that for May based on the actual submission of the waiver renewal. Another major item in the governor's budget is the extension of the quality assurance fee and the associated reimbursement methodology for freestanding nursing facilities. In addition, it proposes a 3.62% annual rate increase during the term of the extension. The budget also maintains the 2014-15 level of funding for the Quality and Accountability Supplemental Payment Program that's intended to provide supplemental payments to nursing facilities based on the achievement of specific quality metrics. A third major initiative is the revised MCO tax. The governor's budget proposes to replace the existing managed care organization tax with a broad-based tax that would comply with recent federal guidance. The federal guidance indicated that the current MCO tax that is only on Medi-Cal managed care plans is likely impermissible under federal regulations, and has required that we seek a new version in this next legislative session. The new tax would apply broadly across managed care plans regulated by the Department of Managed Healthcare and/or the Department of Healthcare Services. The proposed tax is tiered based on various levels of plan enrollment. The tax will be sufficient to raise the same amount of general fund savings that the current MCO tax raises, as well as the funding necessary to offset the 7% reduction in-home supportive service hours. There are several other proposals that will be discussed in more detail later today in the hearing, including the modifications to the Mr. MIP program, annual health plan open enrollment, and pediatric palliative care expansion, but I'll save those to those items. There was one question in the agenda that asked us to talk about the recommendations made by the Legislative Analyst's Office regarding the caseload methodology. In general, we do agree with the LAO's recommendations and have similar concerns about the caseload projections. We are aware of the difficulties in separating the underlying trends in caseload growth from changes brought about by the ACA, economic developments, and changes in the Medi-Cal redetermination process. We are working to resume our monthly caseload reports in the near future. We certainly recognize the importance of having this information available to the public while still protecting the rights of our beneficiaries. Our plan is to have the December caseload posted within the next few weeks and then provide regular updates after that. With respect to the questions raised about the treatment in the estimate of the mandatory expansion, we agree that because the mandatory expansion is really no different than the pre-ACA population, that ultimately there will be no need to have a separate projection. Initially, this large increase of eligibles but unenrolled was not in the underlying trends, so we had to have a separate projection that adjusted both caseload and expenditures, but we'll continue to analyze our data and our approach in advance of the May revision. And then finally, there were two other issues identified by the LAO, the outlook for California's economy's effects on the family caseload, and some concerns about the increase in the senior caseload that we are projecting for the current year. With respect to the family caseload, in developing our estimates, we do include an economic variable similar to what the LAO described, and improving economic trends do reduce the total caseload in general, while a worsening economy actually increases it. Our plan is to continue to use this economic variable in future projections. However, other factors are affecting this caseload, in particular the changes in ACA, as well as the changes in the redetermination timeline, and we'll plan to continue to monitor all of these elements and provide updated trends for the May revision. On the second issue regarding the projected spike in the senior caseload, our data do show an increase in this caseload above the 14-15 projections. We're continuing to analyze the reasons, but we think it's the same reasons as we've been seeing increased caseload in general, the impact of the ACA, as well as the delays in redeterminations. We are projecting that for this population, there will be a return to the slower growth trends in 15-16. And as with other caseload issues, we'll continue to monitor this and update as appropriate in May. So I'm happy to take any questions.
Thank you. Mr. Chu, any questions? Thank you for that overview. You provided a great deal of information and very efficiently, I might add. Thank you. No, you did.
For talking fast.
Actually, you did great. Thank you for that. At least this chair appreciates. We want to have the rigorous discussion, and so thank you for framing it for us in a way that we can focus on the discussion. Let me just ask you this. A lot has been made about Medi-Cal and low reimbursement rates, and I, for one, appreciate the size of California's program. I've spent a number of years, I'm a social worker. I've spent many years working with Medi-Cal programs around mental health and in community settings. and I'm very thankful for the work that you've outlined and that what we're doing here. Having said that, I'm always concerned about those who don't have access to insurance, and a lot's been made about, because of our Medi-Cal reimbursement rates, the inability of folks to find a provider. And so I'd ask you to speak to that and the plans and the administration's view about how we move forward in that environment.
Absolutely. So access to services is something that we continually monitor. I think there's a lot of focus on our fee-for-service rates and being 49th in the nation or whatever the number is. And certainly that's an issue we continue to look at and make sure that there is access to care in that delivery system. But I do think it's important, and we're working on some data analysis to share with this committee as well as the other committees on Medi-Cal rates and access that really focuses on the 80% of our population that's enrolled in managed care, and how the plans pay providers in that case. I mean, plans are required to ensure access to care according to timeliness and network adequacy standards, and we are seeing those being met. We certainly, when there are problems, investigate and work with our health plans to make sure that the access is being improved. So it is something that's important to us. It is one of the reasons why we are also looking at the 1115 waiver renewal that I mentioned as a vehicle to really test some different things to expand access in different ways. Part of the challenge is that the traditional way of providing health care just isn't going to work with so many people receiving coverage. And so how do we start thinking about alternative methods for ensuring people having access to care? Things like that we're going to be experiencing with include things like for specialty care services, the use of e-consults, where primary care physicians can provide specialty care to their patients by just simply having a consult with a specialty care physician instead of having to set up a separate face-to-face appointment with their patient and the physician. We're also working with our clinics on changes to their reimbursement methodology, again, to provide some flexibility to providers to provide care in the most cost-effective, integrated manner possible in a way that's better for the beneficiary. And so those are all the things we are looking at and will continue to look at through this year.
Thanks. I would add one other thing, and that is we certainly would like for you to communicate our interest in seeing as much expansion as can be done. The issue of Medi-Cal reimbursement rates is one that's important to me, too, because I serve in a community that has a hospital that serves some of the most low-income folks. It's called Doctors Medical Center, and it has been and still is on the verge of closure. Its patient mix, probably 90% of whom are either Medi-Cal, Medicare, or no insurance. No health institution has interest in this hospital that could close its doors by the end of this month, which I believe would have disastrous effects. It serves 60% of the residents in the community and is the only true emergency room in the community. I know that healthcare costs are high, but from my standpoint, we've got to have some health safety net for those who just don't have. And by keeping that safety net, we'll keep costs down. So I say all that to say, I appreciate everything in the overview. We'd like you to communicate to the governor our thanks for that, but that we want to have as much support for our public institutions that serve those who can't get support. Thank you. Mr. Chu.
I want to echo some of the comments of our chairman. I understand that the chairmen of our health committees, both in the Assembly and the Senate side, have been looking at various proposals to increase reimbursement rates. And I want to first reiterate my support for that and that effort, and understand from the administration standpoint, how is it that you peg the reimbursement rates where they were, and what openness is there on behalf of the administration to consider these proposals on our side of the House?
Well, in terms of where the rates stand today, I mean, obviously we are enacting, legislation that was passed and signed by the governor in terms of the reimbursement reductions, the 10% reductions that people generally talk about. We have, when we found an issue, been able to administratively remove those. When there is an access issue, we do have that authority, and we've utilized that authority to exclude certain providers from those reductions. Otherwise, the department in and of itself does not have the authority to change those reimbursement rates absent legislation. And certainly I know people will be discussing those legislative proposals. Certainly I can't speak for the governor. I don't know if the Department of Finance has anything they would like to say.
Yang Lee with Department of Finance. We're always open to having those discussions, but for now we don't have any proposals that would increase the reimbursement rates for providers.
And then if I could follow up on just a subset of Medi-Cal coverage, I happen to be one of the members in the Assembly that certainly support increased and expanded Medi-Cal coverage for our residents regardless of immigration status. And we are going to hopefully have a conversation around that. Could you, at a high level, give us a sense of where your department is with regards to, I know at this point we're waiting for federal government decisions around eligibility requirements, but give us an overview on where things stand from your perspective on that. I know this probably is a topic of discussion under the Mr. MIP program. Happy to do that at the appropriate time, but just want to understand from you, particularly in light of the Texas ruling recently, where does the administration stand on how we're going to provide health care to all, regardless of immigration status?
Sure. So certainly with the immigration reform proposed by the president, we are looking at the potential impacts of that to our Medi-Cal program. We do have current eligibility processes in place that allow individuals in statuses like that to receive Medi-Cal coverage. And so we are analyzing what the potential impacts are for that particular order on what our Medi-Cal caseload might look like and the potential fiscal impacts of that. Beyond that, certainly, again, as with the rate proposals, there are legislative proposals out there to expand more broadly, and we're certainly open to have those conversations, but obviously we don't have a proposal right now from the administration.
Thank you.
And thank you, Ms. Chu, and thank you. We will be having a fuller conversation on Medi-Cal rates in our hearing on April the 20th. We invite you all to participate, and so to be continued, and certainly will be an ongoing theme for this subcommittee. Anything else from Finance or from the LAO's office?
Thank you, Mr. Chair. Felix Su with the LAO. Ms. Cantwell did an excellent job, actually, of summarizing our analysis of caseload issues in the budget, and we're also encouraged by the steps she outlined or alluded to that the department will take to work with us on the caseload estimates. So at this time, we have no further comment or recommendation.
Smart people always agree with smart people, so she led it. Anything? Thank you very much. Ms. Cantwell, we're going to be having public comment, but we'll invite you to participate in our next conversation. Do we have any public comment?
Mr. Chair and members, Elizabeth Lansburg with Western Center on Mental Poverty. Pleased to be here. We're very proud of the progress that Medi-Cal has made implementing the Affordable Care Act and the 2 million low-income Californians who now have health coverage. We do want to flag for the committee, we are very disturbed with the build-out of the IT system, that there have been a couple populations left behind. Former foster youth are not being adequately put into Medi-Cal as they should, and our CalHERE system is not putting pregnant women who are eligible for the Medi-Cal Access Program into that program, and so we did want to flag that for the committee. We share Assemblymember Chu's concerns about the DAPA-eligible individuals. As Ms. Cantwell said, under the current law, those folks are eligible for Medi-Cal, and we look forward to having as many of them enroll as possible. We do want to applaud the administration's implementation of the BHT for services for autistic kids. I've almost never seen the department work so effectively with stakeholders and do it so promptly, and we're very appreciative of those important efforts. We would concur with LAO's recommendation about having Medi-Cal caseload growth or caseload reports each month. It is difficult to get data from the department, and we are also concerned that the legislatively required ABX11 report about eligibility enrollment data has not been forthcoming. It was due last April of 2014. We do very much support leaving this item open. As has been noted, we don't know where Medi-Cal renewal terminations basically didn't happen in 2014, and though we think that's a good thing, we know those terminations are coming, and so it really makes sense to leave this item open till the May revision. Thank you.
Good afternoon. Jessica Haspel with Children Now, and I wanted to just continue the comment that Ms. Landsberg just made about the former foster youth population. The law is very clear that they qualify for Medi-Cal regardless of income, and that's been in place since January 1, 2014. Unfortunately, there have been a variety of enrollment and retention barriers for this really high-need, vulnerable population, much of which is a result of programming issues that have not been a priority in terms of high on the list. Our CalHERE system doesn't have any programming whatsoever to determine eligibility for our former foster youth, which means if their information is run through that system at all, they receive an incorrect determination. Some of our youth are just winding up in a wrong program. Others are being told they don't qualify for Medi-Cal at all, and prompted to purchase insurance. This is a huge issue from our perspective and one that really needs corrective action as soon as possible. Unfortunately, the recent 24-month roadmap released for changes to the CalHER system still pushes this back to February 2016. We hope to see that changes and that be reprioritized so that we're not 2 years into implementation and our youth are still getting an incorrect determination. Thank you.
Thank you, Ms. Cantwell. At the start of the next panel, I'm going to ask you to address the issue of eligibility for foster youth in particular, most importantly, what our fix is for the mishaps. Thanks.
Hi, good afternoon, committee members. My name is Tam Ma, and I'm with Health Access California. We are the statewide consumer healthcare advocacy coalition advocating for quality, affordable health care for all Californians. I want to echo the comments of my colleague at the Western Center on Law and Poverty with regards to healthcare reform implementation and the DAPA population. In addition, we agree with the LAO's assessment of Medi-Cal caseload estimates. We appreciate the department's commitment to providing actual caseload information, and we recommend that this committee consider requiring monthly caseload reporting. This information will help the committee to make better decisions since it will have access to better and more timely information. And we also concur with the decision to leave this item open and ask that the committee ask the department to provide this monthly caseload information prior to the May revise and monthly thereafter. Thank you.
A long time ago, Ms. Ma was my student. Now I'm her student. Thank you very much, Ms. Ma.
Thank you. Melissa Cortez Roth on behalf of Autism Speaks and the Center for Autism and Related Disorders. We just want to offer our support for the funding for behavioral health treatments for children with autism in this year's budget. We spent many years coming before this committee asking for this funding, so we do want to recognize the administration for fully funding that and for moving very quickly after CMS guidance and for their very open stakeholder process. Thank you.
Thank you. Let us move forward to the issue of county eligibility, administration, and the COLA trailer bill. And if you would start with, we'll invite our other panelists to join us, and if you would start with the issue of eligibility for foster youth, please.
Absolutely, yeah. I mean, from an administration perspective, making sure that people who are eligible for our program is a very high priority. There have had to be prioritizations of the system changes. We did have essentially, a from-scratch build of a very complicated system that has certainly had its problems, and we've been working to correct those. We are looking at ways to ensure that folks are getting on, even if the system is not working appropriately, and certainly we're open to talking about how to look at the priorities that have been laid out in terms of the CalHERS changes to see if there are ways that we can adjust that.
Could you, do you know how large the problem is with regards to foster care youth? How many young people we're talking about?
I don't personally. I'm sure someone who commented on it might be able to share that, but I don't have that number off the top of my head.
Okay, I'd love to get that information.
We had a report at our previous meeting that at least the number of youth who would emancipate or transition out of foster care would be 2,000 this year, 3,000 shortly following. So we know that's certainly a critical number, and the committee has established that this will be a priority, our support for all kinds of youth, but especially those who are in foster care. So that's my way of saying that we'll be expecting you to work with the advocates on the problems that they've identified, and we'll be looking for some updates on the fix. Okay. Thank you. Anything else, Mr. Chu?
Nope, thank you very much.
Thank you. Would you like to start with your remarks on eligibility? Thanks.
Sure. So this trailer bill proposal would make permanent legislative intent language with respect to the cost of living adjustment for county admin funding for the budget year and in subsequent fiscal years unless otherwise appropriated in the budget. Since 2008-9, trailer bills each year have included this language to suspend the COLA, and this seeks to make that language permanent. As noted in the agenda, the department is working with our county partners and stakeholders on a new methodology for budgeting county administration funds, and that's why we believe this is the appropriate thing to do until we have that new methodology in place. But I'm happy to take questions.
Anything from the Finance Department or LAO's office?
Jennifer Lopez, Department of Finance. On the record, we would like to note that this proposal is consistent with the administration's policy to eliminate COLA statewide. I would like to note the proposal would merely strike out intent language and does not diminish the legislature's authority to augment funding for counties. The legislature still has flexibility to make decisions about county funding levels every year through the budget process. In addition, the state has provided significant augmentations to counties for the Affordable Care Act implementation in the last 2 fiscal years. Thank you.
Amber DG, Legislative Analyst Office. We recommend that the legislature reject the proposed trailer bill language and continue to determine whether to suspend the COLA through the annual budget process, as has been done over the past several years. We find that the decision of whether the COLA should be ongoing should be considered during the development of the new budget methodology.
Thank you. Any questions? We have public comment.
Thank you, Mr. Chair and members. Frank Mecca, Executive Director of the County Welfare Directors Association. Our members administer the Medi-Cal program on your behalf. We appreciate the very good partnership with the administration and the implementation of the Affordable Care Act funding that's been provided. We do oppose the elimination of the statutory COLA. That COLA was added to statute to ensure the efficient and effective operation of the Medi-Cal program. And while it's true that it's been suspended each year since 2006, 2007, we think it's premature to take it off the books. We will be working with the administration to develop a new methodology for budgeting Medi-Cal eligibility based on a statutory directive that we come up with a methodology to accurately fund the work associated with Medi-Cal eligibility, acknowledging that the ACA has really changed our world. Until we come to you with a proposal for a new methodology, we would oppose taking the COLA off the books. At the time that methodology comes forward, if there's an alternate mechanism to ensure the adequacy of that budgeting methodology, the legislature could certainly take an action at that time. Thank you.
Good afternoon, Chair. Tia Orr on behalf of the Service Employees International Union, here on behalf of 22,000 county eligibility workers who administer Medi-Cal on your behalf. We would concur with the statements of Mr. Mecca. A couple of things that I think are important in this process is, one, obviously we believe it's premature to permanently suspend a COLA when you're developing a budgeting methodology. It almost seems like we're putting the cart before the horse. Secondly, I would implore you to seriously engage on the department side and administration side, the line workers who do this work every day. I believe their expertise and their knowledge and their work on cases can definitely influence and educate the process and the overall budgeting methodology. So I would just encourage us to work in partnership a little bit closer together and also see us as a key partner in this process.
Good afternoon. Brian Allison on behalf of the American Federation of State, County, and Municipal Employees. I want to associate myself with the comments of Ms. Orr as well as Mr. Mecca and strong opposition to the permanent suspension of this COLA. We also believe that it's premature to suspend the COLA at the time when we're developing this budget methodology. I'd also like to concur with Ms. Orr in her comments that line workers need to be engaged during this process. We need to make sure that we are adequately engaging the people who perform this work every day to determine how the new budgeting methodology will affect counties in terms of funding. So thank you so much for your time today.
Elizabeth Landsberg with the Western Center on Law and Poverty, and not here to comment on any particular budget methodology, but I just want to say from the consumer perspective what an incredible job the county workers have done with an unbelievably difficult year. I think people know Covered California Service Center, you had to wait more than an hour to get through. People were forced to go to the county. The county quick sort process, they were answering the phone within 30 seconds. Really tremendous rules change like we've never seen before, and we're very grateful to the county workers for all the work they've done. Not to say we don't raise issues with them, of course, but they really have gone above and beyond.
Tam Ma with Health Access California, concur with the remarks of my colleagues and encourage the committee to retain the legislature's authority to consider the COLA on an annual basis until the new budget methodology is in place.